Cardiac arrest is a major global health concern. It accounts for almost 30% of the global mortality rate, with a poor survival rate of in-hospital cardiac arrest. The survival rate for out-of-hospital cardiac arrest, OHCA, is worse. Rhythms associated with cardiac arrest include ventricular fibrillation, pulseless ventricular tachycardia, pulseless electrical activity, PEA, and asystole. The first step in recognizing a cardiac arrest rhythm is establishing that the patient does not have a pulse by checking for a carotid pulse. Ventricular fibrillation is characterized by erratic, rapid, and completely ineffective depolarization of the ventricles. Rather than contracting, the ventricles quiver. This rhythm is fatal if not corrected quickly. Causes. Precipitating causes of ventricular fibrillation include myocardial ischemia or infarction, shock, electrocution, stimulant overdose, and ventricular tachycardia, including torsade de pointes. ECG findings. The rhythm is irregular and there are no discernible P waves, QRS complexes, or T waves. The waveforms that are seen may vary in amplitude from coarse to fine. As ventricular fibrillation progresses, the waveforms may change from coarse to fine and eventually disappear, asystole. Patients in ventricular tachycardia may or may not have a pulse. Pulseless ventricular tachycardia occurs when the ventricles are not contracting effectively enough to sustain sufficient cardiac output. Causes. The underlying causes of pulseless ventricular tachycardia are the same as for ventricular tachycardia and include heart disease or damage. As for myocardial infarction, certain medications and electrolyte imbalances. ECG findings. In pulseless ventricular tachycardia, the ventricular rate is usually greater than 180 BPM, and the QRS complexes are very wide. Pulseless electrical activity, PEA, is a term used to describe several rhythms that are organized on ECG. For example, the QRS complexes are similar in appearance, but the patient has no palpable pulse. The heart's conduction system is functioning, but the myocardium is not contracting, or contracting too weakly, to produce cardiac output, or volume is not sufficient to maintain cardiac output. P may be seen immediately after successful defibrillation of a patient with ventricular fibrillation, or pulseless ventricular tachycardia. But when PEA is the presenting rhythm, primary PEA, the underlying cause is usually a condition that either affects contractility or ejection, for example, hypoxia, acidosis, anterior wall myocardial infarction, or leads to inadequate preload, for example, severe hypovolemia, pulmonary embolism, tension pneumothorax, cardiac tamponade, right ventricular, infarction. ECG findings. In PIA, the monitor shows an identifiable rhythm, but no pulse can be palpated. The rhythm may be sinus, atrial, junctional, or ventricular in origin. The rate may be fast or slow. The QRS complexes are similar in appearance and may be narrow or wide. When the cause of the PEA is cardiac in origin, it is most common to see a slow rate and wide QRS complexes. Non-cardiac causes of PEA are often associated with a rapid rate and narrow QRS complexes. In asystole, there is no electrical activity and therefore no contraction. Causes. Asystole is often the terminal rhythm in untreated pulseless ventricular tachycardia or ventricular fibrillation, or when resuscitation efforts are unsuccessful. Other causes include narcotic drug overdose, hypothermia, myocardial infarction, pulmonary embolism, hyperkalemia, hypoxia, drowning, suffocation, and indirect lightning strike. ECG findings. Asystole is characterized by a lack of discernible electrical activity on ECG, which results in a flatline appearance. Very rarely, the sinoatrial SA node may generate impulses that cause atrial depolarization but are completely blocked at the atrioventricular AV node, resulting in P-wave asystole. When caring for a patient in cardiac arrest, it is important to recognize reversible causes for the arrest and address them. This is especially important with PEA and asystole, which often have reversible underlying causes. The mnemonic H's and T's can help you to remember the reversible causes of cardiac arrest. While resuscitation is underway, review the patient's medical history with the providers who were caring for the patient at the time of the arrest or family members to identify details that could point to one of the H's or T's as an underlying cause. Of particular importance are changes in the patient's clinical condition leading up to the arrest, disorders or situations that could predispose a patient to developing one of the H's or T's, risk factors for cardiac and pulmonary conditions, and medication use. Diagnostic studies that may prove useful for identifying underlying causes of the cardiac arrest include a 12-lead ECG, arterial blood gases, a serum electrolyte panel, chest radiography, and bedside ultrasonography. Although some diagnostic studies can be done while resuscitation efforts are underway, others, such as a 12-lead ECG, should be delayed until after return of spontaneous circulation, RSASC, is achieved. Hypovolemia, a reduction of fluid volume in the circulatory system, develops because of excessive blood or fluid loss, for example, because of trauma, internal bleeding, or severe dehydration. A fluid challenge can aid in determining whether hypovolemia is contributing to the cardiac arrest. Suspect hypoxia in any patient who had respiratory difficulties preceding cardiac arrest. To address hypoxia as a cause of cardiac arrest, ensure that the patient's airway is patent and provide adequate ventilation and supplemental oxygen. Acidosis can impair cardiac function, in some cases to the point of cardiac arrest. Acidosis can occur in a multitude of conditions, including shock, diabetes, and acute or chronic renal failure. Arterial blood gases are used to confirm the diagnosis of acidosis. In patients with metabolic acidosis, the administration of an initial dose of sodium bicarbonate, 1 mg/kg, may be indicated. If administering sodium bicarbonate, ensure adequate ventilation for removal of carbon dioxide, or sodium bicarbonate may worsen intracellular and tissue acidosis. Potassium imbalances can precipitate cardiac arrest. Suspect hyperkalemia in patients with acute or chronic renal failure and in those who had wide QRS complexes and tall, peaked T waves on ECG prior to the arrest. Several measures may be taken to reduce potassium levels, including administering sodium bicarbonate, glucose and insulin, or nebulized albuterol. Sodium bicarbonate is the preferred method of addressing hyperkalemia in patients in cardiac arrest because it causes a rapid shift in serum potassium level. Other therapies take much longer to work. Suspect hypokalemia in patients with dehydration or overuse of diuretics. In hypokalemia, flat T waves, prominent U waves, and possibly prolonged QT. Intervals may be seen on ECG before arrest. Treatment is intravenous administration of a dilute solution of potassium chloride. For patients with severe hypothermia, body temperature less than 30 degrees, and cardiac arrest, core rewarming with cardiopulmonary bypass, extracorporeal blood warming with partial bypass, or thoracic lavage with warmed fluids is indicated. Warmed fluids and warmed humidified oxygen may be administered as adjunctive therapies. Overdoses of both illicit and therapeutic drugs and poisoning can induce cardiac arrest. Drugs that are frequently implicated in cardiac arrest include cocaine, methamphetamines, opioids, heroin, fentanyl, B blockers, calcium channel blockers, digoxin, and tricyclic antidepressants. Reversal agents are specific to the toxin, for example, glucagon for beta blocker overdose, sodium bicarbonate for tricyclic antidepressant overdose, naloxone for opioid overdose. Cardiac tamponade occurs when fluid accumulates in the pericardial sac, compressing the heart and preventing it from pumping effectively. Causes of cardiac tamponade include trauma, cancer, renal failure, infections, and idiopathic pericarditis. Cardiac tamponade may also be seen postoperatively. Pre-arrest physical examination findings may include the 3 cardinal signs of cardiac tamponade, Beck's triad: hypotension, weak pulse or narrow pulse pressure, muffled heart sounds, and jugular venous distension. In a patient with PEA, narrow QRS complexes and electrical alternans, for example, beat-to-beat variation in the amplitude of the QRS complexes, may be seen. Treatment is pericardiocentesis, needle aspiration of fluid from the pericardial sac. Tension pneumothorax occurs when air accumulates in the pleural space, causing the lung on the affected side to collapse and the mediastinum to shift, compressing the heart and vena cava. Compression of the vena cava leads to impaired venous return and decreased cardiac output. Penetrating chest trauma is a common cause of tension pneumothorax, but the condition can also develop in older patients with underlying lung disease and in patients who smoke. Pre-arrest physical examination findings may include hypotension, tachycardia, absent breath sounds on the affected side, jugular venous distension, hyperresonance on percussion, and tracheal deviation away from the affected side, a late sign. Difficulty ventilating the patient may also be a sign of tension pneumothorax. In a patient with PEA, narrow QRS complexes should raise suspicion for tension pneumothorax as a possible underlying cause. Initial treatment is with needle chest decompression or thoracostomy. In massive pulmonary embolism, obstruction of the pulmonary artery, and the release of vasoconstrictive mediators from the thrombus lead to cardiogenic shock, which can quickly lead to cardiac arrest. Conditions: in the patient history associated with prolonged immobilization or venous stasis, hypercoagulability or damage to the veins should increase suspicion for pulmonary embolism as a potential cause of cardiac arrest. Witnessed cardiac arrest and respiratory distress before arrest also may point to pulmonary embolism as the cause. PEA is the initial rhythm in 1/3 to 1/2 of patients with cardiac arrest caused by pulmonary embolism. Fibrinolytic therapy may be initiated for patients with known or suspected pulmonary embolism. Myocardial infarction can lead to cardiac arrest. If a pre-arrest 15-lead ECG shows an inferior wall myocardial infarction with right ventricular involvement, evidenced by ST segment elevation in lead V4R, then impaired preload is likely the cause of cardiac arrest, and fluid bolus therapy should be provided during resuscitation. If a pre-arrest 12-lead ECG shows anterior wall myocardial infarction, then impaired contractility is the likely cause of cardiac arrest. When myocardial infarction is the suspected cause of cardiac arrest, a 12-lead ECG should be obtained after ROSC is achieved to guide therapy, and inotropic support may be needed to address cardiogenic shock. After determining that the patient is not responsive, not breathing, and has no pulse, call for additional resources, the rapid response or resuscitation team, and the resuscitation equipment or cart, and initiate CPR immediately. Without interrupting high-quality CPR, attach the cardiac monitor defibrillator and identify the arrest rhythm. When a patient is in cardiac arrest, treatment focuses on providing high-quality CPR, providing shocks if the rhythm is shockable, or early epinephrine if the rhythm is non-shockable, and, if possible, determining and addressing the underlying cause. For non-shockable rhythms, epinephrine should be administered as early as possible. For shockable rhythms, medication administration should be delayed until after at least 2 shocks have been given. Placement of an advanced airway and establishment of capnography should be delayed until after at least 2 shocks have been administered in the case of a shockable rhythm, or CPR has been provided for at least 2 minutes in the case of a non-shockable rhythm. Ventricular fibrillation and pulseless ventricular tachycardia require defibrillation as soon as possible. Because shocks may not be successful, or, in the case of successful defibrillation, the resultant rhythm may not be adequate to sustain perfusion or a pulse, resume CPR immediately after each shock. After every 2 minutes of CPR, reassess the rhythm while minimizing interruptions to chest compressions to determine next actions. If the rhythm is shockable, resume CPR immediately and administer 1 shock as soon as the defibrillator is charged. If the rhythm is non-shockable and organized, attempt to palpate a pulse. If a definitive pulse is palpated, the patient has return of spontaneous circulation and post-cardiac arrest care should be initiated. If a definitive pulse cannot be palpated, resume CPR immediately and follow the code card pathway for a non-shockable rhythm. Repeat cycles of 2 minutes of CPR, rhythm check, shock, and medication as appropriate until the rhythm check reveals a non-shockable rhythm, return of spontaneous circulation is achieved, or the resuscitation effort is terminated. Clinical indications of ROSC include a palpable central pulse and measurable blood pressure, a sudden and sustained increase in ETCO2, or an arterial pulse waveform on an arterial line when no compressions are being delivered. Additional signs, such as patient movement, normal breathing, or coughing, may be present. The energy dose depends on whether the defibrillator is biphasic or monophasic. Providers should familiarize themselves with the equipment used in their facility. Various medications may be used in the treatment of ventricular fibrillation or pulseless ventricular tachycardia. Remember that in cardiac arrest, all medications administered through the IV or IO route should be followed by a 10 to 20 ml normal saline flush. After 2 shocks have been delivered, epinephrine, 1 mg IV IO every 3 to 5 minutes, may be administered. After 3 shocks have been delivered, consider administering an antiarrhythmic agent. The initial dose of amiodarone is 300 mg administered as an IV IO bolus. If the arrest rhythm persists, consider giving a second dose of 150 mg after the 5th shock. Defibrillation is not indicated when the rhythm is PA or asystole. Management of these rhythms involves providing continuous high-quality CPR, administering epinephrine, 1 mg IV IO repeated every 3 to 5 minutes, as early as possible and performing rhythm checks after every 2 minutes of CPR. In addition, it is extremely important to look for and address potential underlying causes of the cardiac arrest. P and asystole often have an underlying cause, and unless that cause is addressed, the resuscitative effort will not be successful. Repeat cycles of 2 minutes of CPR, rhythm check, and medication as appropriate until the rhythm check reveals a shockable rhythm, ROSC is achieved, or the resuscitation effort is terminated. Post-cardiac arrest care includes interventions aimed at optimizing oxygenation, ventilation, and perfusion, minimizing the systemic consequences of cardiac arrest, preventing future cardiac arrest, and assessing the patient's prognosis for recovery. If not already done, place an endotracheal tube. If an endotracheal tube is already in place, confirm proper position and patency. Start ventilations at a rate of 10 breaths per minute and adjust as necessary to keep carbon dioxide levels in physiologic range between 35 and 45 mHg. Maintain an oxygen saturation, CO2, of 94% to 99%. Target a minimum systolic blood pressure of 90 mHg or a mean arterial pressure, MAP, of 65 mHg. Initially treat hypotension with a 1 to 2 well intravenous IV isotonic crystalloid fluid bolus. If the patient fails to respond to fluid, consider starting an IV vasopressor infusion. Obtain a 12-lead ECG expediently. As time and resources permit, obtain a medical history and complete focused physical and neurologic examinations. Maintain euglycemia and identify treatable underlying causes, including H's and T's. Diagnostic studies aid in determining the pathophysiologic consequences. Targeted temperature management protocols should be considered for all patients who remain comatose after ROSC, as indicated by an inability to follow verbal commands. A target temperature between 32 degrees and 37.5 degrees is established. The patient's body temperature is maintained at the targeted temperature for at least 24 hours.